Hi, and welcome to yet another episode of the Vet Dental Show. Today, we're going to feature Dr. Mark Epstein. Dr. Mark Epstein is a specialist in pain management and one of the best speakers, if not the best speaker in the world, and one of the most knowledgeable, if not the most knowledgeable, in pain management. And he has, in the very recent past, done a course for us on pain management, and this is a segment out of that course. And if you are enjoying this episode and would like the entire course, I'll give you that information at the end of the show. Right now, enjoy Dr. Mark Epstein.
Let's cover some pain-modifying analgesic drugs that are parenteral, like, for example, Librela is. And ketamine is one we talk about it at length about for perisurgical pain. It's pretty much a settled matter, including the kind of some unifying protocols, which are reproducibly pretty good for both people and the ones we use for dogs and cats. But what about chronic pain? We know that it can work in chronic pain conditions, neuropathic pain conditions. The problem is that the way it's administered, the route, the dose, the frequency, for what conditions, for how long, and none of that is worked out on the human side. So there is no unifying protocol on the human side. We would not expect, obviously, to have one on the canine or feline side as well. Adverse effects, we don't know about that either, because here you're doing it not just once, but repeatedly over time, probably. And maybe if your dog has unstable angina, so dogs don't get heart attacks, and so that's what might be worried about with them, with people, but generally considered very safe. The two different ways that are probably being used most predictably, I'll begin with Dr. Lindsay Fry here. She does what amounts to, I'm oversimplifying a little bit, but she uses the perioperative protocol, and she does that 2 weeks apart for 3 times, sometimes more, sometimes less, for up to 3 or 4 months. So she's accruing some data. We hope to see that in print at some point in the future. Then there's this device on the left called the actuator. It's a sub-Q infusion device that the dog kind of wears as a backpack, where they can get a 24-hour sub-Q infusion. So with that in mind, more data to come. I think we're going to find there's something to all of this. But in terms of some kind of ideal protocol, that'll probably take quite some time to come out. Dr. Fry's technique does use a loading dose, just like with that perisurgical, and she just goes ahead and a lot of the other stuff you see here is for induction or pre-medication purposes for surgery, anesthesia and surgery. She just gives a bolus of ketamine that you see here. That's her technique. And you might suspect that in an HCM cat, this would not be something you want to do. But nevertheless, that's how she proceeds with her dogs. You probably have heard about using ketamine sub-Q at this point, 5 mg per kg dose once a month. I have too. It comes from this website out of the UK, which is a really good website, to be honest with you. And the part that I quibble about it is when it talks about this protocol, because if you go to the site for it right now, even, it'll say, there's a story. It's like, I know a guy. I've heard some people doing this, and these dogs seem to get better, and so on. And I have to remind the listeners here about that caregiver placebo effect, that half the time, up to half the time you do anything for a dog, even giving it nothing, that is a placebo, they're going to look better to you or to the owner just because of that caregiver placebo effect. The expectation for improvement, the hope for improvement is enough to lend that bias. These low doses once a month do not strike me as a lot of ketamine, maybe / enough ketamine, whatever that means. I'm putting in air quotes here. It's inexpensive and it's safe to do. I would not dispense syringes to the owner to do, because ketamine is a scheduled drug and can be diverted and abused. Nevertheless, there you go. Have I used it? I've tried it. I'm a little underwhelmed, to be honest with you, but I'm just one person. So there you go. I think I'd be remiss if I didn't mention it and let you know that it's out there. The next parenteral one is going to be bisphosphonates. And in the original presentation, I actually was mentioning pamidronate, but I'm going to change my gear a little bit because I think there's a better protocol out there, certainly easier and safer to do. And keep in mind that about 3 out of 4 dogs with osteosarcoma will get better by freezing that osteoclast. The osteoclast is what is responsible for the neurochemical signature that really begins to amplify pain. In fact, by definition, creates a neuropathic pain state with these dogs. And the benefit can be sustained up to 3 months in about a third of dogs. It can be used with chemo and it can be used with radiation therapy. So we're going to talk about zolidronate. It's way more potent than pamidronate, but the protocols are quicker and easier and probably less nephrotoxic as well. So you can see the dose here has been worked out. There are higher doses that are published, but we're going to go ahead and advise sticking to this 0.1, 0.15 mg per kg. And simply, you just put it in a relatively small volume of fluid and you give it over 15 minutes. And by the way, 15 minutes, not more, not less. It just seems to be the safest way to give it. Some doctors will, or some sources recommend basically maxing it out at 4 milligrams, which is 1 vial. So you have to put it in those fluids that don't have calcium in it. So that would be just basically sodium chloride. And even though it's less nephrotoxic than pamidronate, you still want to monitor your kidney values. And I'll talk about what the likelihood is of a nephrotoxicity in just a minute, because that's been worked out pretty well with zolidronate. This is just an example of a patient of mine. So osteosarcoma of the distal tibia, left tibia, and we simply put the pamidronate in 250 mLs of saline, and we set it at a liter per hour, and that delivered 250 mLs in 15 minutes. And we just did it right in the exam room while the owner was waiting. So fairly easy to do. Now, how often? Generally, we're doing it about once a month. Some dogs will need it maybe a little bit more often. Some dogs a little bit longer, can go a little bit longer. And try not to get it out of the vein. We haven't had a problem yet, so I'll just say I'm not sure what happens when that gets extravasated. And we don't want to do any kind of dental procedures or bone procedures just because it can lend itself to pathologic fractures, so we don't want to mess with that. Now, what about the renal injury? Turns out that it's pretty uncommon, and even if the BUN and creatinine starts to climb, it doesn't mean you have to discontinue it. So just keeping in mind that osteosarcoma, if you're doing a limb-sparing medical therapy, it's the pain that's going to be the terminal event for these dogs, right? So as soon as they're uncomfortable enough, they can't rest, they can't conduct activities of daily living, is when the euthanasia occurs. So you can conclude that if the creatinine climbs a little bit, it doesn't mean you have to stop the zolidronate. In this particular study, out of 44 dogs, only 6 of them had an increase of azotemia, and of those, only 2, they felt like they really had to stop the zolidronate. So this was, and I should make a mention that NSAIDs and anesthesia didn't increase the risk, because osteosarcoma does upregulate COX enzymes in general and EP4 receptor in particular, that they should be on NSAIDs, unquestionably. So it can be given safely. With the 2 classes of drug can be given safely together. So this is zolidronate given sequentially over several periods of time. Some of these dogs got a little bit of a higher dose. And of the 95 dogs, there were only 8 that ended up having azotemia that began to occur. And even then, they couldn't be sure that it was zolidronate doing it, but it was well tolerated. So I'll just leave it at that. You watch the renal values as long as the therapeutic is working, the patient is not symptomatic for its renal disease, you can consider to continue it. And only in the extreme might you have to discontinue it. I mentioned that it can be done with other therapeutics as well, including radiation. Palliative radiation can reduce pain as well. If you're going to do it, this study answers the question, should you do it before, during, or after? Which should come first, basically? The study answers that question. It says, ideally, if you're going to do both, which you ideally should, radiation first, then followed 24 hours later by the zolidronate infusion. Now, it doesn't say whether or not by freezing the osteoclast, is the bone actually stronger? Does it actually minimize metastasis or pathologic fracture? And the answer, we don't know, but if you do it with radiation, it seems like it just might. So I'll just leave that kind of hanging in the air. Another parenteral drug is maropitant, and I mentioned in my original presentation that there was data that suggested that there was a pain-modifying effect, but as it turns out, when you look at the big picture, it just is not, looking at dogs and cats, that there's a max-sparing effect, but there's not a lot of evidence that has a pain-modifying effect. When you try to separate patients that are feeling better post-op, is it because they're feeling less likely to have to throw up, or they have a better appetite? versus less pain, that's hard to tease out. So this systematic review says, you know what, it can reduce anesthetic requirements, but doesn't seem to have an effect on inflammation and pain. But here's my big but, is that these studies upon which the systematic review was based, they were all spay models. And substance P and K1 that it binds to, but doesn't really upregulate, it doesn't really figure into pain processing unless there's sensitization. It's part of the sensitization process, central sensitization in the spinal cord. So does a spay in a well-done ovarian hysterectomy, would or does a spay cause sensitization? In other words, where substance P and NK1 is involved? I don't know. I wouldn't think so, actually, to tell you the truth. So this is not the best population of patients to study it in. So what if we were to narrow the scope of patients that we were thinking about and say, okay, what about patients that were getting a visceral pain, like pancreatitis pain, for example, or resection anastomosis, that type of thing? And for patients that had a lot of soft tissue damage, these were where sensitization occurs. Let's take an example because we actually have a study to look at it. So these are dogs undergoing mastectomy for, I beg your pardon, this was a study since a systematic review. I'm getting ahead of myself a little bit, looking at morphine, maropitant, and dexmedetomidine. And the upshot is that adding the maropitant in, the serine in, was additionally anesthetic sparing and spared opioid as well. So that's a hint that it may have some pain modifying effect. This is the one I was just going to reference. That these are dogs getting mastectomy, so a lot of soft tissue damage, right? Radical mastectomy. And essentially, in the dogs that were given maropitant IV and then followed by CRI, that it was able to have these patients more comfortable post-op than if they had not received the maropitant. Their pain was less. So with that in mind, I think that lends credence to the idea that in a subpopulation of patients, visceral pain and patients where you would suspect a central sensitization component, wind up, if you will, that maropitant not only can help with maintaining appetite post-op, but also decrease vomiting, but also have a pain modifying effect. And that may not even be the end of the story, because maropitant may be delivered in other ways. This begins to talk about nanoparticles, and all of these studies that you see here are talking about maropitant delivered through nanoparticles. And so it seems that if we can change the way that we're giving it through a different technology, in fact, that the likelihood of it eliminating, of being a pain modifying appears to go way up. Without going into all the technical pharmacology of nanoparticles, it seems to have that kind of effect. So we're going to begin to wind up a little bit. I'm going to show you myself getting a PRP injection in the shoulder. This is me getting it in the elbow of a dog and getting it in the knee of a dog. And so this is platelet-rich plasma. So I'm going to use this as a kind of a metaphor for talking about all the interventional kinds of techniques that are out there. Not even all of them, but a good chunk of them. And I hope you like the sterile technique this gentleman's using, sticking this big needle in my shoulder. It's really, apparently, I still pop in there. I was give me a little pat. I guess I was a good boy. Okay. All right. So there's all kinds of things, and beginning with saline and corticosteroids. And I mentioned saline and corticosteroids because, first of all, saline, if you inject it into a joint, guess what? It reduces pain in the joint. Probably dilutes inflammatory mediators and other things, but everything has to be compared to that. Corticosteroids do too by reducing inflammation, but it actually has a chondrotoxic effect. So we try to avoid that. And people is a little less concerned about it because they're eventually going to replace your joint. Here, we're trying to spare as much cartilage as we can. And you have all these different kinds of techniques and products. So just like real quickly, HA, long been available in humans and horses, and we can use these products in dogs as well. But there are some important guidelines that have been coming out on the human side where they begin to omit it as a first-line agent, mainly because its benefit over and above and beyond saline is a bit questionable based on systematic reviews and meta-analyses. When it comes to other therapies, that they're much more predictable in their effect. So whether we want to use these in dogs and cats, I just take the Fifth Amendment. I never have. Others do and find it helpful, maybe in combination with other things, but I just have to leave it at that. And then we have stem cells, and I'm not going to give you a ton of data, only to say that obviously there is data to support that they can and do good things. They do not replace chondrocytes. It's not like we regenerate new cartilage, although theoretically it can do that. It's not what happens. It basically has a protracted anti-inflammatory effect in that joint. But when we look at it, there's both benefit, but the studies are heterogeneous again. There's a lot of bias in these studies. So we still have a lot more way to go to determine the best way to do stem cells, because there's all these different techniques about how you collect them. Do you culture them? Do you not? And I could just go on and on. So there's much more that we need to learn over time. PRP, because you don't have to harvest the stem cells. The PRP is much easier, platelet-rich plasma. But here again, there's all kinds of different PRPs, different technologies, and are they platelet-rich? Are they I beg your pardon, are they leukocyte-rich, leukocyte-poor? Are they activated? Are they not? And I could just go on and on. It does seem to work, but we don't have a consensus on the best way and product to use, but it is what we use in our practice. We use the Arthrex device. Should you decide to use any of the things we've just discussed, these are some doses and schedules that are out there in the literature. I'm going to let it hang here for a second, just in case you want to take a screenshot. Then we got all these others that were on the previous slide. So I'm just going to, run through a couple of them that are out there. This is the one that is not merely investigational. It's actually a commercial product in here, and it targets the synovitis. The synovitis is what drives the progression of degenerative joint disease and osteoarthritis. So the theory being that if you can dial back or button up the arthritis, maybe you can not only get pain relief, but you can slow down the progression of the disease. And when we get synovitis, it's not just a little inflammation in the lining. It's like these gigantic fronds of neovascularization that are chock full of not just blood vessels, but nociceptors as well. So the product that we have is this 10117 product. It's called Synovetin OA, given by injection right into the joint. It is a radionucleotide. It's not like I-131, which is systemic, but it stays pretty much right into the joint. It does not go systemic. There's the product. And the data out there goes like this, that at least the one study that they produced that has this pain modifying effect for kind of up to a year, which is pretty impressive. And by the way, they use the elbow, which is, of course, as you probably know, and I mentioned, is one of the most refractory to try to treat. This is the study right here. Now, I'm not saying that this is, ideal for every dog. If you decide to do it in practice, you have to go through all this regulatory stuff. You have to have a radioactive material license. You have to have a radiation service officer that actually supervises your facility. There are some of these that are in the U.S. A lot of them are places that already had their license for I-131 in cats, and they just amended it to be able to do this, because this is actually easier and less environmental contamination than I-131. They ship it to you in a lead-lined container. You inject it in the joint. You're wearing just regular personal protective equipment. But a disadvantage is the people still have to keep their distance for X length of time, generally a couple of weeks at bigger distances, and then gradually getting to shorter. But for example, if the dog is used to sleeping in your bed, none of that, not for a few weeks. And so that's a disadvantage in the post-op, and the owners have to be prepared for that. So you've got all these kind of disadvantages. It's not going to be the most inexpensive thing in the world, but it's probably not outside doing stem cells. Probably the same price range as something like that. Okay. And with that, I want to thank you very much. I'm going to stop my share and tell you that I've really enjoyed teaching this class. I look forward to meeting you all at some point in the future.
I trust you enjoyed that segment that Dr. Epstein provided for us today. If you're interested in registering for that entire online course, yours forever, 24/7, go to the link ivdi.org/pain and use the promo code PAIN. You'll get access to that and can download it and listen to it immediately. Hope you had a great week. Hope you have a wonderful week coming up, and we'll see you next week. Take care.